Hello, I'm at the Ankara University with my surgical team. In this section, we will demonstrate the surgical technique of the perineal part of the extra-levator abdominal perineal excision. At this point, I would like to thank to all my staff for their great teamwork. Following the completion of the abdominal dissection by laparoscopy, and colostomy is created at the left iliac fossa. A pelvic drain is placed. Then the patient is ready to be turned over. At this stage, all the staff at the operating room has to work as a team in harmony. The anesthesiologist takes care of the airway and hemodynamic monitorization. Other staff turn the patient over with the guidance of the anesthesiologist. The legs of the patient are separated and the purse string suture is placed around the anus before starting the sterile covering. To a better surgical access in the perineum, buttocks are separated. Then, second purse string is applied. This will prevent contamination of the surgical wound. Surgical incision from coccyx to perineal body is performed around the anus. Dissection is carried out just outside the external anal sphincter and then carried out between the ischianal fat tissue and the levator muscles. There is no need to remove neither large skin area nor ischianal fat tissue unless the preoperative radiologic imaging shows invasion of these tissues. The dissection continued laterally within this perimuscular plane until the levator muscles reach the lateral border of the pelvic floor. Here, perimuscular dissection plane is demonstrated in detail on another patient. The dissection is continued laterally within this perimuscular plane until the levator muscle reaches the lateral border of the pelvic floor, near to their origin. As you can observe, the levator muscle is going to the lateral of the coccyx, passing under or in front of the coccyx. Same dissection plane is taken on the other side. We have mobilized the levators almost up to the pelvic side wall and to the obturator muscles. We can stop the dissection at this point. Before transecting the sacrococcygeal joint, perimuscular dissection must be completed on both sides of the rectum. Now, let's move back to the first patient. Transection of the sacrococcygeal ligament and the start of the dissection at the extra-levator plane is viewed here. The aim of the removal of the coccyx is to provide wide surgical margin. Following the transection of the sacrococcygeal ligament, mesorectal fascia is observed from the perineal wound. In order to achieve wide surgical margin, pelvic floor must be removed en bloc with the mesorectum. Levator muscle is transected at the border of the lateral pelvic side wall. This transection is carried out from posterior to anterior at both lateral borders of the pelvic wall. Then the specimen is removed from the perineal wound. This maneuver allows us to view the anterior dissection plane of the rectum clearly. Progress has to be made under direct vision and sharp dissection between the rectum and the urogenital organs, seminal vesicles and the prostate. Here you see a better way of doing a perineal part of the abdominoperineal excision. Sharp dissection under direct vision is essential. The removal of the denominal fascia with the specimen is clearly demonstrated. Animation presents seminal vesicles, prostate, neurovascular bundle next to prostate. In addition to schematic presentation of urogenital organs, the denominal fascia and the specimen are shown here. Here we view the specimen. Note that levator muscle is attached to the mesorectal fascia. Then, eventually, the specimen is extracted. Please note that, as surgeons, before sending your specimen for pathologic examination, make sure you evaluate your specimen quality carefully. In this case, for example, evaluating my specimen, I realized that I should have stopped the posterior dissection 2 cm before reaching the pelvic floor. The perineal defect is closed primarily. Moving back to the second patient, we can see the neuromuscular bundle on the right side, next to prostate. Here, we observe the dissection plane in front of the prostate. Once we have entered the correct plane between the denominal fascia and the prostate, progress has to be made under direct vision. In order to save the patient's sexual function, it is important to identify the nerves on both sides. We try to ease the neurovascular bundle from the specimen. Here, we view the nerves once more. Following the removal of the specimen, it is necessary to secure this wide pelvic outlet. Here, the insertion of the Permacol mesh is viewed. Permacol is a biological material, is now being stitched to the origin of the levators. Closed suction drains are placed on both sides of the mesh. Then the wound is closed. Now, let's turn to a female patient and view extra-levator abdominoperineal excision technique. Here, perineal part of the extra-levator abdominoperineal excision will be presented. In this case, the tumor is located in the anterior part of the rectum, 2 cm above the dentate line. Surgical incision from coccyx to labium is performed around the anus. As it was demonstrated in a male patient previously, the dissection planes are same. Dissection is continued just outside the external anal sphincter and then carried out between the ischianal fat tissue and the levator muscles. Again, the dissection is continued laterally within this perimuscular plane until the levator muscles reach the lateral border of the pelvic floor. Transection of the sacrococcygeal ligament and the start of the dissection at the extra-levator plane is viewed here. The removal of coccyx with the specimen gives us wide surgical margin, providing us with space. Following the transection of the sacrococcygeal ligament, mesorectal fascia is observed from the perineal wound. In order to achieve wide surgical margins, the pelvic floor must be removed en bloc with the mesorectum. The levator muscle is transected at the border of the lateral pelvic side wall. Then the specimen is removed from the perineal wound. This maneuver allows us to view the anterior dissection plane of the rectum clearly. Progress has to be made under direct vision and sharp dissection. Good lightening is essential. Since the tumor is located at the anterior wall of the rectum, dissection planes also include the removal of the posterior wall of the vagina en bloc as well. The bleeding from the edge of the vagina can be controlled by electrical surgical instruments. Unfortunately, to achieve wide surgical margins, the whole posterior wall of the vagina is resected en bloc with the rectum, leaving a small vaginal remnant behind. No doubt, the quality of life is not only affected by a permanent stoma, but also the removal of the vagina. Then, eventually the specimen is extracted. The specimen is carefully assessed before sending it to the pathology lab. Suture closure of the edge of the vagina secures hemostasis. Following the removal of the specimen, hemostasis is checked once again. The perineal defect is closed primarily.